And we are back. We are going to finish up this one little slide and then move on to the next set of notes, which is blood vessels. This one little slide is left over from blood pressure. I didn't realize I left one man behind. So here we are. Looking at this picture, this is our little kidney. Here. Okay, and the kidney, it's a really bad drawing. I apologize. I will erase that. Our kidney is a strong regulator of blood pressure because it needs to have a certain amount of blood coming to it to be filtered through. Actually, our whole bloodstream is filtered through every 45 minutes. So we've got to have a good amount of blood supply coming to the kidney on a regular basis so we can filter blood, keep it clean, regulate pH, and also ion balance in the body. So these little kidneys help to regulate this system through, I don't know if you remember JG cells. We don't need to remember them at this point. We'll go over them when we talk about kidney. Let's just remember the release of renin. You probably remember renin-angiotensin system. So here is step one. Our kidney sense that blood pressure is falling and says, whoa, Nelly, we've got to increase the blood pressure. So it releases renin to the bloodstream. In the blood, renin finds angiotensinogen. And here's that ending again, OGEN, which means an inactive form of something in the body. Angiotensinogen is the inactive form of angiotensin 1, and renin converts angiotensinogen into angiotensin 1. Angiotensin 1, and this all happens in the bloodstream, by the way, is then converted to a stronger, more potent form known as angiotensin 2. It is converted from 1 to 2 by ACE, or angiotensin converting enzyme. This is where we get ACE inhibitors to work, right here. ACE inhibitors will stop that conversion of angiotensin 1 to 2. Angiotensin 1 is a mild form, which will also increase blood pressure, but it's very mild compared to angiotensin 2. Angiotensin 2's got it all going on. It does a multitude of things. It's going to systemically raise blood pressure. It actually will slightly constrict all the blood vessels. So if we're looking at the diameter of the blood vessels, and they get all just a little bit smaller, it's that garden hose theory again. If we put our thumb over a garden hose and we make the diameter smaller, we increase pressure. If we do that through the entire body, we'll increase systemic blood pressure. Angiotensin 1 also helps with salt retention. And the way it does this, I'll tell you what salt retention does. It releases aldosterone from the suprarenal glands or the adrenal glands above the kidneys. And these guys have all sorts of stress hormones. And one of those stress hormones is aldosterone. Cortisol is another one, for example. So the adrenal glands release aldosterone. Aldosterone reabsorbs salt from the kidneys. Well, let's just say reabsorbs salt. We'll get into specifically how that happens when we get to kidneys. Reabsorbs salt, and where salt goes, water goes. Think about it. If you've ever eaten a really salty meal, you retain water, and your body is trying to balance the fluids inside of your interstitial tissues as well as in the bloodstream. And if you have a lot of salt, you're going to retain water to try to balance those fluids out. That's the primary job of aldosterone. It reabsorbs salt into our bloodstream and our body tissues. Where salt goes, water goes. Where we retain salt and water, we're actually increasing the volume of blood. Think about it. I've told you several times, the cardiovascular circuit is a closed circuit. If we put more fluid into it, we will have an increase in blood volume, which leads to an increase in blood pressure. Angiotensin 1 also stimulates the sympathetic nervous system, which will increase heart rate, increase blood pressure. Angiotensin 2, did I say 1? I meant angiotensin 1. Angiotensin 2 also stimulates thirst receptors in the brain, so we drink more water, and that'll increase the fluids in the body as well. And all of these things increase blood volume and also cause a slight increase on all the blood vessels systemically, and this will raise blood pressure. Whew, that was a chunk of change. Kind of glad I put that on its own. If you review this a time or two and it still doesn't make sense, or you need me to review anything, shoot me an email. Be happy to get back to you. Blood vessels, miles and miles of them. Oh my goodness, they're everywhere. It's amazing. And they're going to be the primary highway through which we will send out nutrients and oxygen via the blood. So arteries. Oh, I don't like this definition. Let me tell you why. This is from your book. Okay. Arteries go away from the heart. Veins go toward the heart. Okay. For the majority of cases, arteries have oxygenated blood. Veins have deoxygenated blood. There's a couple of exceptions. I'm going to talk to you about. The pulmonary circulation is the opposite. Okay, the pulmonary arteries have deoxygenated blood. The pulmonary veins have oxygenated blood. So it's kind of the opposite. So anyway, their definition is true for the majority of blood vessels, but there are some exceptions with arteries and veins. I want you to remember that arteries go away from the heart, A matches A, and veins go back to the heart. Now, what happens is arteries lead to smaller arterioles, and those arterioles lead to capillaries, which are 1 cell thick. The reason our body and capillaries really are in these capillary beds, we don't just have like one capillary. We have a multitude of them that form these capillary beds here. Okay, and these capillary beds will feed all the tissue in this area. Now, the reason the arteries become smaller arterial and then an even smaller capillary is so we can make a 1 cell thick membrane here. That's all capillaries are thick. They're only 1 cell thick. And what that does is that allows our body to get substances across them, out of the bloodstream, and into the tissues. And then it allows us to reabsorb substances back into the more venous side of it, so we can get those waste and carbon dioxide substances and gases back into the venous system, back to the heart and the liver for reoxygenation and more nutrients. So it's just important to understand that capillaries are 1 cell thick, and that is why we go from the large artery to our smaller arterioles to our teeny tiny capillaries, so we can get substances across the capillary walls very easily. Okay. After we absorb nutrients, we'll put the waste back into the capillary bed, which will go into the venule. This venule will go to the large veins, and the veins will go back to the heart. Just keeps going over and over. And this is systemic that we're talking about, not pulmonary. When we talk about the blood vessels themselves, if we were to take a blood vessel and cut it and look inside of it like a tube, the inner layer is a tunica intima, the middle layer is media, the outer elastic or connective tissue layer is adventitia. Okay, so 1, 2, 3 are those layers. And I have a picture of it, and I'm going to tell you the difference between arteries and veins in the next slide. Now, here's your exception. The pulmonary artery carries deoxygenated blood away from the heart. Pulmonary vein carries oxygenated blood to the heart. So just make note of that difference. Looking at the inside of the walls of blood vessels. This picture's a little small, but this top one is an artery. I'm going to cut it right, just like that. The middle one is a capillary. This is in your book if you're having difficulty seeing this. And this bottom one is a vein. Okay. With the artery, the middle layer, this one right here, is thicker. That little middle muscular layer is thicker. Okay? And that is because the blood pressure coming out of the heart is higher in the arterial system because it's closer to the origin of the pump of the heart. So we have a nice, thick, muscular middle tunica media to create a little resiliency in that arterial system because of the increased pressure in the arteries because it's so close to the heart. Okay, so tunica media is thicker in arteries. Capillaries are that one cell thick, and you can actually see, you can probably see this better in your book. These are the one cell thicks that are lining right here, and you can see red blood cells in the capillary itself. And the cool thing is that capillaries are just about bigger, or a little bit bigger than red blood cells. So when a red blood cell is in that capillary, it can offload its oxygen to both sides very easily and allow oxygen to get to those tissues. So that's kind of cool. Now, tunica externa, or the connective tissue on the outside of veins, is bigger than the connective tissue on the outside of arteries. So in the arteries, tunica media is bigger to provide that resiliency in that higher pressure arterial system. In the venous system, the outer connective tissue layer is a little bit thicker to anchor those veins because they're a little bit flimsier than the arteries, and they anchor the veins in the surrounding tissue. The other main difference I want you to make note of veins is that they have valves in them. And these valves, much like the heart, help promote a one-way direction of blood so we don't have a backflow into the venous system. When we have a backflow, we get varicose veins because that backflow will pull back into the P-O-O-L, not P-U-L-L, pull back into the veins, and the veins stretch and get distended, causing varicose veins. Okay, so in veins, there's a couple of things that help return blood to the heart, but this is a big one, the valves in the veins. Okay, so arteries to capillaries, well, actually arteries to arterioles to capillaries, capillaries lead to venules to larger veins. In addition to the veins returning excess fluid to the heart, the lymphatic system does as well. I have a little picture in the next slide. The lymphatic system not only provides some immunity, it also returns excess interstitial fluid to the circulation. We know this in patients who have difficulty with edema. Their lymphatic system, either in that leg or that arm, is not working correctly. That's right. That's when we have them put on the socks or the armbands in order to help to return fluids and push the fluids back to their heart. And those lymph vessels are kind of interspersed in the same area as those capillaries and throughout the body. We see on here all these different lymph vessels. We have a whole bunch of them bringing lymph back up from the lower extremity. You don't need to know all these individual names. I do want you to know thoracic duct, that's the main one that drains the lower extremities. It'll come up and into the subclavian vein. Okay, and then the ones in the upper extremities will drain into the subclavian veins as well. You already know about tonsils and lymph nodes and thymus and spleen. I think those are pretty much review. We know lymph nodes. We know these lymph vessels are similar to small veins that help to return fluid from the extremities. In the small intestine, there is a very strong immune system, and those are known as Peyer's patches. They're a series of collections of lymphocytes that are just under the surface of our GI tract that helps to fight off all the infectious agents that we ingest. We'll get into those in the future. Lymph node we know, and bone marrow is where everything happens, right? Where everything is created, I should say. It is question time. Arteries always move away from the heart. Is this true or false? What do you think? Take a minute, answer that, and then let's move on. Cardiovascular diseases. So now we're moving into, we've looked at the structures. We're going to look at what goes wrong. Lots of stuff can go wrong. Oh my goodness. There's tons and tons and tons of things that we could go over. So we're going to keep it somewhat condensed, believe it or not, but try to give you a really good overview of cardiovascular diseases and why they happen. Now, you do not need to know everything that is listed on this slide. Your book kind of has grouped everything that we're going to talk about under here, so you can kind of look back at this slide after you're done studying if you want to. But I want you to understand with these conditions, it'll result in a decreased cardiac output, which is a problem. We've got to get the blood out of the heart so it can get to the tissues, perfuse the tissues, and get back to the heart and get regenerated with oxygen and nutrients. So just think of it that way. We've got to make sure that we get as much blood out of the heart as we're going to get back to the heart so we can keep the circuit going. Alterations resulting in altered tissue perfusion. Okay, this is the inability to push the blood out to the tissues to perfuse. I think this is a very familiar concept for you guys. Perfuse the tissues with enough fresh nutrients and oxygen to make those tissues function properly. Okay. And you could see, basically cardiac output will be a functional abnormality with the heart itself, where it can't obviously pump the blood out. I won't, like I said, I won't make a list of all these things. And then lack of perfusion is the lack of blood getting out to the tissues. So an aneurysm somewhere in the periphery, if you get a clot, if you get a blocked blood vessel, my gosh, I had a cadaver once. I'm going to go off-road in here for 2 seconds. I had a cadaver once that we dissected, and he had so much atherosclerosis blocking his common iliacs, where they bifurcate right off the aorta. They usually had a bypass from his left subclavian artery down to both of his legs. It was a solid mass. So obviously his lower extremities were not getting perfused, right? So perfusion is going to be the inability of getting blood out into the tissue so they can get fresh nutrients and also get rid of waste, right? Okay. Alterations resulting in both hypertension and shock, okay? Because that'll alter the blood going out to the tissues as well as coming back to the tissues and out of the heart. Pericarditis is an inflammation of that pericardial sac, and this can be a viral infection, trauma, MI, TB, you name it. It could be a multitude of things. Fluid will accumulate in that space between the pericardial sac and the heart, giving us pericardial effusion. Remember I mentioned earlier that pericardial sac, guys, is tough. If you were to open up a chest plate and dissect the heart out, pericardial sac is tough. It's almost like a Glad bag, like the black one that you use for really big bags of garbage. So if you get fluid that accumulates in that pericardial space, your pericardial sac isn't going to stretch out. It's going to compress. That fluid will compress in on the heart. and give us pericardial effusion. We'll talk about what that does in just a second. That swollen tissue will create friction. It'll be very painful for your patient. Cardiac tamponade is that cardiac compression from the excessive fluid accumulation. It's life-threatening. I'm sorry, excuse me. This will mean, if you're compressing the heart, your heart space and the ventricles and the atria are now too small to allow fluid to get back into them. Right? Okay, so your arterial pressure will fall because if you can't get enough blood back into the heart, you can't get enough out to maintain a proper arterial pressure. Rising venous pressure, because the blood can't get into the heart, it's backing up into the venous system. You could get distension of the, ding, 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 any guesses? Jugular veins is going to be an obvious symptom of this. Narrowing pulse pressure, because those two pressures are getting closer together, muffled heart sounds. So obviously you can have heart failure, shock, and death as a side effect of this. Constrictive pericarditis is the loss of elasticity. You could get a thick and fibrous pericardium. This is chronic inflammation or some sort of damage that has happened, as opposed to the fluid. So these manifestations are lists of things that can happen. Sharp, sudden, severe chest pain. I think that would be a really good sign, along with your pericardial friction rep when you're trying to listen to the heart. Okay. When we're talking about these heart problems, pretty much everybody is going to have, dyspnea, dizziness, a lot of, these kind of common symptoms. Infective endocarditis used to be called bacterial. I remember it as infective endocarditis. Maybe you learned it as bacterial. It's an infection of the endocardium and the heart valves. By some means, normal flora of either strep or staph has gotten into our blood. They used to say that this happened through dental procedures, possibly. But really, if you get one of these into your bloodstream and it gets into the heart, it can cause an infection in the heart. And you get what are called vegetations. And those vegetations are basically growths on the inside of the heart. And I believe it really likes to form on the valves. And what happens with those vegetative forms, which are like a bacterial overgrowth almost, on these internal structures, is they like to form microthrombi. Nobody likes to throw clots, right? This is a very bad thing because we'll throw those clots, they'll travel to other locations. And so just as a little refresher, a thrombus is when a blood clot is attached to something and not traveling. An embolism is when it is traveling. I'm sure you know that, but let's just, review it. And an embolism is bad because it'll travel until it finds somewhere to lodge into, causing either an MI or a stroke or a pulmonary embolism. Myocarditis is an inflammation of the myocardium. I don't think it's quite as common as the other two. Organisms can also travel through the blood and get into the muscle tissue itself. I think that's the key why it's a little less common, is because it would have to get past the endocardium or the pericardium to get into that myocardium. So generally infections will stop either on the outside or the inside. This is kind of nasty if this does happen, though. You can have heart failure, can progress to cardiomyopathies, which we'll talk about in a little bit, dysrhythmias and thrombus formation. So let's take a minute and practice our itises. Itis as an ending is bingo, inflammation. So this one, I don't think this picture's super obvious. So I tried to put an arrow like here it is, so just think about it. What we just talked about itises. Which one would be your best choice out of those? Infective, shouldn't have said it. Yeah, infective endocarditis. This one, you pause the tape. Oh, I forgot to cover that other one up. You probably already knew it anyway. Cardiac tamponade. You can see the compression of the heart. And once again, that pericardial sac is tough. It's not going to expand with fluid. It's going to compress the heart. And last but not least, what I had to sort of pull for this offline, that red inflamed area is going to be your myocardium. So that one is going to be myocarditis. Okay. Okay. So I am going to pause the tape at this point because I'm trying to keep them all about 25 to 30 minutes. And we'll move on to the next segment in just a little bit. Shoot me an email if you have any questions. Catch you in the next video.